Hello, everybody. Hopefully we're live this evening. The button says we're live, so that's a good start. We've got one person in the chat. It would be great if anyone's here. Start letting us know that you're here in the chat. We'll give it a few minutes just before we kick off, and then we will get started because I don't want to take up your valuable, what night is it? Tuesday evening. Oh, we've got a few. There's a few people coming in. Hello, everybody. Mods, it looks like, according to the Medall feed, it looks like the audio is working.
I agree.
Grant, thank you. Hello, thanks, Charlotte. Cheers. It's better to find out at the start than at the end if there's an issue. But we'll give it till 4 minutes past, and then I'll get started. Yeah, that's really important that Dr. Asif has just raised in the chat that we do have moderators on hand tonight. So while I'm going to be giving the talk, if you have questions or comments or things that you would like advice or help with, there are points in the talk where I can try and deal with them, but throughout the chat, our moderators will be your go-tos to try and get some speedy answers and make sure that everyone can get the help that they need. Okay. It's 4 minutes past, so I think let's make a start, and we'll welcome anybody new as they arrive. So welcome to this first lecture tonight in a series that goes by Ready, Set, Burst. I'm going to actually put my slides in front of me so that I can see. This is, in a very simplistic sense, this is a multi-part series. It's 4 online lectures, the dates of which are on the screen now. And it's all about research excellence. That really is the best way of thinking about it. We've got some really fantastic speakers lined up. And tonight I'm going to be taking you through the first session, which is all about essentially what happens after medical school. What's going to be the beginning of your medical career and understanding what comes next. And that's really going to be focusing on early years and perhaps middling years medical students, or those who are later on in the course and don't have a good handle on what's coming yet. And then the later sessions are going to be much more practical about how to do the things that are going to score you points and get you academically where you want to be. So we've got sessions on audits, which are very important, collaborative research and publishing, which is something that everyone realizes is important, and then a session on critical appraisal, which will be a panel session. And critical appraisal is one of the most important skills in academic medicine. You know, anyone can put a paper down in front of anyone. Anyone can write a paper that says anything. The trick is in knowing if that paper actually makes sense and if it's good. So my name is Ollie. For some context, I'm an academic FY2 doctor working in the Northeast, and I'll talk about more of the specifics of my journey in a little bit. coming to the end of my foundation training now, in my final rotation with my ARCP next week, which is a very exciting time. So just to jump in, what is medical school ultimately about? Like, why do we go there? What are we hoping to get out of it? Why do students go to medical school? Well, the thing is, right, medical school isn't this kind of magical machine that turns people into doctors. That's not really what it's supposed to do to any straight degree. It's not a case of saying, you know, can we put a random person into a medical school and they'll come out as a competent practicing doctor. It doesn't really work like that. Medical school is a bit like a boot camp or a training ground, and it's about giving you those basic skills on which you can build, right? So in order to be able to break the rules and form clinical practice, you have to know all of the rules. Or to analogize, you can't play a board game, right, until you know all of the rules. You can't start to play more specific versions or variants of a card game until you know all of the rules. And you have to know them well enough to operate within those rules, even in situations that don't quite fit. And that's what medical school is really about. It is a very, very broad, as you'll all know, foundation in the fundamental basic sciences, those being anatomy, physiology, biochemistry, pharmacology, pathology, however you subdivide it. And that's important because on these foundations, you can build any kind of physician or surgeon. So if you want to be a cardiologist, or you want to be a neurosurgeon, or you want to be a pediatrician, at some level, all of those doctors will have a standardized minimum set of knowledge and skills. And the fact that they all have that same standardized skill keeps patients safe, because we know what it's reasonable to expect doctors to know. And that sets a minimum safe standard for practice. That's what medical school is about. Tonight's talk is what comes after medical school. What happens when we get after this phase? And the details of this, I don't think are especially important. I think it's about broad principles. But given that so many medical students, certainly myself, they tend to be quite goal-oriented, right? They want to know what's coming next. They want to have something in the distance to point at and to work towards and say, yes, I'm going to go and be a dermatologist, or I'm going to publish a research paper, or I'm going to go and do an elective in Portugal, or whatever. They tend to be quite goal-focused. And so I think it's very helpful to a large group of people to understand what can exist in the future, what comes next, and fundamentally this, to know what your options are. Because to borrow a phrase from Simon Fleming, the orthopod reg, who was now recently CCT'd, his orthopod consultant, you can't be what you can't see. And so we need to see everything that there is to know what comes next. And we'll divide this into the broad pathways that most people will follow, and then where the opportunities are to move away from those pathways. Now, people get a bit uncomfortable about moving away from pathways, but actually it's really, really common. Very, very, very few people will deviate. Very few people don't deviate from the traditional path, I should say. And I'll talk more about that as we talk about specialty training. So this is going to be the big fundamental thing, right, that hits you when you come out of medical school, the foundation program. This is a program that consists of 6 4-month rotations taken over 2 years, which come as a package set of 6 programs. So you don't get to decide, for example, I want to do 4 months of cardiology, then 4 months of respiratory, then 4 months of surgery, then I'd like to do 4 months of pediatrics. It's not mixing and matching. It's not picking and choosing. It's this package of 6 I like better than this package of 6. So you're applying for a package of 6 programs in most places. There are some exceptions to the rule, but they are very few. So for most people, this is how it all works. You're applying for this package set of 6. They come over 2 years, obviously, FY1 and FY2. They have slightly different expectations between those 2 years. But another way you might look at this is that you're going to spend 3 of your 4-month rotations as an F1 with 1 set of roles and responsibilities. and then 3 4-month rotations as an FY2 with a slightly more senior set of roles and responsibilities, and be expected to do slightly more. As an FY2, that's the start of being the SHO, or the ward senior house officer. Now, foundation year 1, this is the important thing, your first year of clinical practice. This is what's required to get your full GMC registration, or your license to practice, as we often call it. In order to be independently licensed and work as an autonomous medical practitioner, you need to be fully licensed to practice. And that includes working at hospitals outside of your own trust, effectively. Foundation year 2 is then required in order to enter specialty training for UK graduates. I think I've included a bit for IMGs later, but I'll make sure it's addressed if I don't. So, to give an example, we have Dr. Smith, who graduates from Manchester Medical School this summer in 2023. She will then go and complete the following foundation program, which is 4 months of acute medicine, 4 months general surgery, then pediatrics, then trauma and orthopedics, then general practice in the community, and then finish with 4 months of accident and emergency medicine. And this is a really key thing. Virtually all, and I say virtually all, it will be like 95%, but there is some wiggle room. Virtually all programs will include exposure to a mix of things. That's what the foundation is supposed to do. It's supposed to expose you to lots of different areas of medicine, with at least one rotation in an acute medical specialty, so either A&E or acute internal medicine. And that's what's called being on the acute take. You should be seeing an undifferentiated acute take. That is, seeing, clerking, admitting, forming a diagnostic and management plan for new unseen patients that you will see and examine yourself and then discuss with a senior. I think it's probably the most important rotation that any of us will do in the foundation program. It's a bit unlike anything else. And then you'll do at least one community specialty as well. This can be anything. Most commonly, the ones that you'll see it as are general practice, obviously, because it's a community-based specialty, and psychiatry as well is very common. So that's where I'm doing my community placement. In our second example, we have Dr. Rossiter, who will graduate from UCL Medical School as an example in 2024. And she goes on and completes the following program: 4 months in HPB surgery, 4 months of acute medicine, 4 months of renal medicine, 4 months of older people's medicine, 4 months in ENT, and 4 months of hematology and oncology. And again, this is a perfectly reasonable foundation program. Gives you a good mixed range of specialties, lots of medicine, 2 different surgical specialties. I haven't actually put a community rotation on there. Let's say that the older people's medicine is a community Jerry's rotation. But again, that's the point. Broad strokes, mix of specialties. And you'll all spend, or you should all spend, at least some time carrying a cardiac arrest bleep or phone as well. That's one of the really important experiences that you'll get during the foundation program. So like I said, you're building a generalist base in acute and general medicine and in surgery, so you can handle a very wide range of situations if you're presented with them later. Virtually all of you should become ALS qualified at some point during this process. So my cohort all did it in FY1. And ALS, or advanced life support training, means that you're capable of leading a cardiac arrest situation at least until senior help arrives. So you should be able to recognize and initiate treatment in a cardiac arrest situation until med-reg or anesthetics or someone comes to help. And of course, the other point is to prepare you to apply for specialty training, for what we call core specialist training. And as you move up the training ranks, you will take on additional responsibility. So not only will you be setting off in your specialty training journey, but you will also be responsible for supervising FY1 and FY2 doctors and those lower on the training ladder than you. It's a continuous process. Obviously, you go higher up the ladder, you help bring people up the ladder below you. Now, there's a portfolio to deal with, just like you'll be used to at medical school. We use a system called Horus, the Horus e-portfolio, which seems to be pretty standard for the foundation program in England. And this is just an example of what it looks like. I'm not going to go into it, but just as you are expected to fill out perhaps reflections and supervised learning events, maybe procedures, DOPSes, case-based discussions, all of these things that you're used to, you will be expected to maintain a portfolio that is what we call contemporaneous. That is, that it's timely. So you update it as things happen, and you update it throughout the year, not just at the end of rotations or not all before your final ARCP. You keep a diary essentially throughout the year, and that is how you pass your ARCP with no issues. Now, that's the foundation program. One of the alternatives that you can go down at this stage is called the Specialist Foundation Program, or the SFP. Now, you do this at exactly the same stage. So you've finished medical school. You're going to go on and do 2 years of further training before you can apply for specialty training. But this one is the Specialist Foundation Program. It used to be called the Academic Foundation Program. And the way it works in the broadest terms is one of your rotations, so one of your 6, remember, package deal rotations, is exchanged for an academic or a specialist block. Now, usually, again, not always, I'm going to say that a lot throughout tonight's talk, usually but not always, there are no hard and fast rules in medicine ever, especially not in medical careers. I'm just trying to cover my own back because there will always be an exception. Usually, these are themed in either research, leadership, or education, as in teaching, but not always. Sometimes they're completely unspecialized and you can do whatever you like. Sometimes they are incredibly specifically themed and you will be working on a very specific project with a very specific supervisor. They may be themed around a specific specialty, which is something to bear in mind if you have a particular specialty in mind. They often come with funded qualifications, such as postgraduate certificates, which normally cost about several £1,000s. They can be funded as part of these specialised programs and will count towards your specialty training applications. They are seen as prestigious, for better or worse. I'm not 100% sure that that's a good thing necessarily. I think that SFPs are a great thing for the right person. I don't think they're the right thing for everyone. But because they only make up about 5% of all foundation program places, it goes up or down each year, but it's about 5%. Because they are highly competitive, they are seen as prestigious, and therefore, again, you can use them as evidence later on. But because you're swapping one of those rotations for your academic or specialist block, and you only have 5 4-month rotations of clinical experience, that means that you have less time in which to become as good as your peers who have the full 6 rotations. And that's up to you, whether you want that kind of pressure. I've not found it to be too significant a problem, but you do have to try. You can't be complacent about this. And you also need to understand, especially if you're an early years medical student now, or you're thinking about these specialized foundation programs, it's a very different ball game. To some degree, the point of the foundation program is all about eliminating differences between graduating doctors and turning them all into a kind of big homogenous mush that will go around the country and fill all of the rotas that need filling, and everyone should have a broadly similar experience. So it doesn't really matter where each individual goes. What matters is that all of the rotas are filled, and to some degree that's the function of the foundation program. The SFP is kind of the opposite of that, in that it highlights differences between individuals. So it's much more looking at skills in research, education, leadership. publications, presentations, whether that's posters or oral spoken presentations, winning prizes, having interesting experiences, all of these things are valued. And the question is, what makes you stand out? That's really what the Specialised Foundation Programme is about at this stage. It's what makes you stand out, and how can we take those skills, those features that you have, and how can we allow you to build on them and excel in some other way? That's really the point of the Specialised Foundation Programme. Now, the process for these two is the same, whether you choose to do the regular foundation program or the academic specialised foundation program. But you must submit a standard foundation program application before you can apply for the SFP. The only reason why that's important is that if you are not successful in getting one of these specialised posts, it means that you will fall back into the standard foundation program recruitment process and you will still have a job, which is obviously the most important thing. You will then be competing with everyone else for foundation program jobs in exactly the same way as everybody else. Oops. There are these things called white space questions, which are kind of like mini personal statements of about 300 or 400 words. And they'll usually ask you for your thoughts on, it might be something like, what is a big unanswered question in medicine? Or tell me about your leadership experience, or tell me about when you did research, or tell me about when you solved a problem. Kind of like mini interview questions. And you'll also have to upload and submit a portfolio, which is publications or research articles, journal papers, presentations, so if you've spoken at conferences or meetings, and prizes. So that might include things like academic prizes, merits, distinctions from your exams, research grants, bursaries, essay prizes. There's a million things that can go under prizes, and lots of people will have a few things. You can only submit to 2 academic units of application. I'm not going to go into the weeds of this, but basically with the foundation program, you'll broadly apply to all of the big geographic areas in the UK. So it might be, the Northeast, Scotland, Devon Peninsula, that kind of area, London or North London or whatever it's split down into. And you can apply everywhere that you want for the standard foundation program. With the academic foundation program, or specialised even, you're limited to 2. So you have the possibility of interviewing for 2 of these jobs, and obviously if you're successful, you'll go on and do one of them. If you're not, again, you will re-enter into the standard foundation program. The major difference is that the specialised foundation program will require you to pass an interview, which will test your academic program and your clinical, your academic knowledge even, and your clinical skills. So expect a clinical interview. They're usually done online, or at least they have been in recent years, but I would expect a clinical viva, because you have to be good, because of course you will have less time than your peers to get clinically good as a doctor. If successful with one of these specialised posts, you'll find out much earlier than everyone else where you're going in early January, February. It'll be more April, May for people doing the standard program. Now, there are 2 other interesting choices that you have when you leave medical school now, one of which is the Foundation Priority Programme, which is a recent thing that was introduced to recruit graduates to underserved areas or specialties that don't get enough applicants every year. And the way that they do that is they come with a perk of some description. So usually that might be a funded qualification, or something as simple as an enhanced salary package. So, for example, I know some of the doctors, I work in Newcastle, some of the doctors that work in Carlisle, I think receive something like £7,000 a year additional salary, simply for working there, because it's recognised as an underserved area. I think it's a really progressive way of solving that problem. It's less competitive than the SFP, but it comes with many of the same perks in that you know where you're going to go, you know where you're going to be working for 2 years. you'll find out early on what you're doing, and you get one of these perks without all of the rigmarole of portfolio and prizes and everything else that you need to do. It is, however, the major drawback with this is that because it's about recruiting people to underserved areas, it's only available in certain parts of the UK. For example, not very many in major metropolitan areas where lots of people want to go and work as doctors, because that's obviously kind of the point of this. The other one is the Psychiatry Foundation Fellowship, or PFF. This is a program that's intended to essentially give very focused support to those graduating doctors who want to go and do psychiatry. So you decide, you know, at the end of medical school, hey, I'm interested in doing psychiatry. What it does is things like provide you with specific ring-fenced funding for going to conferences, funding for projects, and regular meetings with a psychiatrist to supervise you, make sure that you're progressing and help you get into psychiatry. Now, the interesting thing here is that there is no tie-in. You are absolutely not required to apply for psychiatry at all if you don't want to after you finish this program. It gives all of the same competencies as the foundation program because it's all delivered on top of the standard foundation program. So, you know, for anyone who wants to do psychiatry, it's clearly a great thing. For anyone who maybe is not sure whether they want to do psychiatry or not, it might be worth it to get that extra degree of support, funding, access to research opportunities and things. Think about it. It's not something that I would rule out early if you're at the stage where you could apply for it. Now, how would you choose a program? Well, they're all challenging for different reasons. This is a historical slide that I've taken from an old presentation, and I'll talk about it in a minute. The SJT, or the situational judgment test, has played a significant role in where people get allocated in the country. That's this national examination that tests your clinical judgment skills. Well, it's situational judgment, really, rather than clinical, just like the one you would have taken when you applied for medical school as part of the UKCAT. Historically, this was given in combination with your academic performance at medical school, what we call your decile. So those two things were important, basically, to allocate where people went in terms of their geographic preferences. If you wanted to be in London, you would need a high academic performance throughout medical school to get high decile, and you would need to score well on the SJT. The Specialised Foundation Programme doesn't use the SJT at all. But as we said before, it requires strong portfolio, good interviewing, good clinical knowledge, good networking, all of these kind of academic soft skills. Now, this is a really important thing for you guys watching. For 2024 onwards, so that will be people who are going into selection, who are entering into the selection process for foundation this September, or whenever the process starts. So to start in summer 2024 as new doctors. The way in which all of the allocation is going to work is set to change. The details have not been published at this point in time. I've just explained how it used to work. It used to be basically how strong was your academic performance at medical school and how well did you perform on the SJT exam that everyone in the UK sits. We are moving away from this model, it seems like, towards a preference-informed model, where you would instead rank maybe your top 5 deaneries, your top 5 geographical areas. So you might say, my top 5 might be London, Oxford, Cambridge, Bath, and the West Midlands or whatever. Because apparently this results in more people being happier and getting a choice that they're more likely to like than basing it on these points systems. It's out for consultation. A final decision has, as far as I know, not been made yet. So I'm really sorry. It sucks. For next year, we don't know how it's going to work. Nobody knows. So keep your eyes peeled for that. Everything could change. How much will you be paid? And we're going to stop for a break in a minute to answer any questions. The foundation trainee salary when you come out of med school is about 29,000 a year, just over, rising to about 34,000 in FY2 now. Obviously, strike stuff notwithstanding. You can expect anything between kind of 5,000 to 8,000 a year higher, as that is our full-time equivalent salary, adjusted for 40 hours. Obviously, we don't work a 40-hour week. As doctors, we tend to work anywhere up to 48 on average. So you will earn additionally, as a lot of those hours will be predominantly antisocial, including nights and weekends. As an FY1, it depends on your specialty. All of this is very dependent on your specialty and your workload. You could expect maybe 2,200-ish after tax. As an FY2, I found that it's about 2,400, again, depending on your rota. When you graduate, you don't get paid usually until the end of August. So watch out for that, especially as you'll have big financial outlays with moving house, renting a new place, deposit on a new place, etc. Anything that you do that reduces the hours you work will reduce your pay. You can undertake bank work, which is the equivalent to locum work inside your own hospital as an FY1. You can do full locum work in any hospital you choose from FY2 onwards. And that's the time where we're going to take a break, because I'm very ill and I need to let my voice recover. So we're just going to hold it there for 2 or 3 minutes, and I'd be very happy to take any questions or comment on anything that needs commenting on. It's a lot of information. Thanks, Narek. Me too. I've been off work today, so just been resting my voice all day, ready for this. But you can tell, I'm sure, that I'm a bit muted compared to my normal self. Charlotte is saying, with locum shifts, are they done on a national system, or do you have to apply individually to the trusts? That's a good question. It does vary, and it really depends. So where I am, I do all of my locum work through what's called the staff bank. So I get emails from essentially all of the departments at the hospitals where I've worked, which is 2 or 3 now. And they'll say, you know, we need a doctor to cover this department on this day. This is the rate for these hours. Can anyone email me back? And that's the way it works here. In different parts of the country, there are often locum agencies, so sort of apps and things called like Locum's Nest is an example of one. So you sign up through this app, and then any of the hospitals that locum agency serves will go out to advert on the app, and you would sign up on the app. So it really depends what people are doing, kind of where you are in the country. Like I say, where I am, it's mostly done by word of mouth. Yeah, see what Dr. Asif's just commented there. Like, that seems like a really good system. Ours doesn't work anything like that. That seems really efficient. So, you know, it varies. They're different amounts of organized. The only thing that I would say is that organizing stuff directly with your trust will often get you more money than going through a locum agency, right? Because a locum agency will take a cut of whatever they charge the trust for your labor, because that's how they make money. It's far easier for a rota coordinator or a trust to employ you directly and give you an escalated rate. than it is to go through a locum agency, which will cost them more to get you the same doctor. So being friendly with rota coordinators is very helpful, and if you're reliable as well. If you're known to be flexible and able to to pick up shifts on short notice or to change things around, you'll get called more often. You might Niharika, you've just asked about how the SFPs will work from 2024. It's a good question. We don't know. I suppose the thing to say is that deciles won't necessarily go away. Obviously, they're just generated from the data that medical schools already have. So SFP processes could still use deciles if they wanted to, even if those deciles weren't going to be used for the foundation program. But because they can choose, basically each individual academic unit for SFP can choose to do literally whatever it wants. It's a wild west. So they could still say, we're still going to use deciles and we still expect fourth decile or better or whatever, as London used to do. But yeah, I agree with you, Charlotte. It's very frustrating. None of it, as far as I can tell, is evidence-based in any way. My firm opinion is that it's all cost cutting. I think that's what it's all about. It's the only explanation that makes sense to me. It's how can we process this very high volume of people as cheaply and quickly as possible. Anyway, let's have a move on. We're into the second half now, and the second half is much shorter, so we're nearly there. Just to illustrate for you what I've done thus far when I left medical school, because I think people find it helpful to understand what people have actually done, not just saying, this is what you can in theory do. It's, this is what people have done. This is what they do. So I've done an academic foundation program in medical education research, which again, super niche. There's probably a handful of med ed research programs that exist. It's a niche within a niche. So it's not about teaching. It's about researching the why behind teaching, which is very interesting. So that's my themed academic foundation program. Before it was renamed to the SFP. So I'm hanging on to that. I was my cohort were the last cohort of academic foundation doctors. In my F1, I did 4 months of transplant surgery, which ruined me. 4 months of academic rotation with general medicine on calls. Then 4 months of acute medicine, so that's on the acute take, carrying the cardiac arrest bleep. Then in my F2, I did 4 months of neurology, which I really enjoyed. Then 4 months more of academic, because again, just to show you how unusual things are, if you do the Newcastle Specialised Foundation program, it comes with 2 academic rotations. So I've only done 4 clinical jobs in 2 years. And then finally, I've ended up on an academic psychiatry job, which is very strange, but I work on a clinical trials unit for psychiatric inpatients. So I've done probably getting on as much research in this non-academic psychiatry job as I did in my academic jobs, because of how the job is and how the atmosphere is. What am I doing next? So these rotations have set me up very well to go and do my F3, if you like, or a non-training year in neurosurgery down in London, which is exactly what I wanted to do. So I feel very privileged. And yeah, so that's where I'm at. That's what I'm going to go and do next. So you can see how all of these pieces fit together. Now, we're going to spend about 10 minutes talking about specialty training, again, at the very broad level. It's just so you understand what's coming. What is specialty training about? Like, why do we do it? This is the process by which you turn a generalist physician, which is what we're all trained as, into a specialist one. Someone who, instead of knowing a little about a lot, which is doctors in general, it's turning that person into someone who knows a lot about a little, into a specialist physician. And we have to remember that generalism itself, paradoxically, is also a specialism. So just because people working in general practice or in acute medicine are extremely good generalists, that is the virtue of their specialty. That is itself their specialty, if that makes sense. In the UK, to enter specialty training, it requires completion of the foundation programme. So that's the important thing for UK graduates. Now, for international medical graduates, this is what I was talking about before. You've got a few routes into specialist training. You can either complete the foundation programme, if you can apply to it directly. You can undertake a standalone FY2 post. These are quite competitive, but they are available, which again give you the same certificate of completion. Or you can do what's called a CREST form, which is a certificate of readiness to enter specialty or specialist training. And the important thing with this, I don't know the details of it, but I can tell you that it does not need to be signed by a UK consultant. A CREST form can be signed by a consultant practicing in a country outside the UK. So if you're wanting to come and do training in the UK or work in the UK, a CREST form may be the way that works best for you. So it's just important to have a read around, understand the options, and see which one is going to make the most sense. They come in one of two forms, one of two flavors, specialty training programs. The most common, and that is to say that most specialty training pathways are like this, are what we call uncoupled. That means that they consist of two distinct phases. You have a core training phase and a higher training phase, with entry to both of those stages being competitive. Pardon me. Entry to that higher stage of training usually requires having passed your collegiate exams and being a member of the college. So, in fact, I'll go through an example in a sec. So let's say you want to be a cardiologist. You'll do your FY1 and FY2. You then need to do internal medicine training, what used to be called core medical training, but now is called internal medicine training. And by the end of that time, by the end of those 3 years of internal medicine training, you must have passed your MRCP, your Membership of the Royal College of Physicians exams, and PACES, which is the clinical exam. And that would make you eligible to apply for ST4 cardiology training. And then you do that from ST4 to ST8, and then you'll get your cardiology CCT, certificate of completion of training, and you can become a consultant. And many specialties now will dual qualify in your primary specialties. So that might be cardiology, neurology, respiratory, whatever. You'll dual qualify in that and general internal medicine, which is a relatively new thing. But so you get two qualifications basically. To give a surgical example, you want to be a urologist, let's say, given that this is being done under the purview of BURST. You'll do your FY1 and FY2. You would then need to complete core surgical training, or CST, which takes 2 years. So 2 years as a surgical SHO. You would then, by the end of that, so by the time you reach the end of CST2, you would need to have passed your MRCS, Member of the Royal College of Surgeons, Part A and Part B. That would make you eligible to apply for an ST3 post in urology, or the surgical specialty that you're interested in. And again, you would carry all the way through until ST8, where you would become a single CCT urology consultant. And that's the way most surgical specialties work. Anesthetics is really complicated, and I'm not going to go into the weeds of trying to work it out because I don't care. But it has a core phase, which is taken up either by core anesthetics or ACCS, which is it's called the acute care common STEM pathway, which gives you a bit of experience in kind of emergency medicine, anesthetics, acute medicine, basically all of the adrenaline junkie types of medicine. You do that for 3 years. I think it does ITU as well. You need to pass your primary FRCA exam, and then that would make you eligible for higher anesthetics training and working towards becoming an anesthetics consultant, with the option to dual CCT in intensive care medicine, if you so wished. This is obviously absolutely not an exhaustive list, but most specialties work something like this. You have a lower phase of training, which is more generalized and less specific, and then you have a higher phase where you become a registrar in one specialty and you work towards being a consultant. The alternative is what are called run-through training pathways. These are essentially the niche hyper-competitive specialties, and the reason that they're like this is that you go straight into them after FY2. So instead of doing multiple phases and multiple rounds of selection, you apply straight after FY2 into ST1 specialty training. And once you're in, so you have one entry process, once you get in and you get that ST1 post, you are in training until you reach consultancy. So you go all the way through the program, usually for 8 years, but it depends on the program. However, these only exist for a small number of specialties. So it's things like radiology, pediatrics, ophthalmology, neurosurgery, cardiothoracics. The general principle is, if the specialty is so niche that learning generalist skills are not going to be helpful, or are not going to be a good use of your time, if you think about core surgical training, it's not going to be useful for a neurosurgical trainee to spend 6 months doing knees and hips and then 6 months opening up abdomens with the general surgeon. It's probably not a good use of their time, given that 90% of the time they only operate above the neck. Specialty selection is the point, more or less, now at where your portfolio really comes into its own. There are really broad domains that are important to be aware of, those being audits, presentations, publications, prizes, experience in teaching and training in teaching, which are not the same thing. Increasingly, we're seeing a trend towards the MSRA, or the multi-specialty recruitment assessment, being used for selection, which, surprise, surprise, has an SJT in it. Wouldn't you believe it? It's basically a GP exam. That's what it was designed and developed for. However, because it's cheap and easy to mass deploy and it generates a bell curve of scores, more specialties are using it now, including surgery, and that was a real game changer last year. I'm not going to talk about any of this stuff in tonight's talk, but that's what the rest of this series is all about, is helping you with this stuff and about excelling in the academic side of your portfolio. Where do I go for help? This is a big question, and you will need help. Very few people can go it alone in medicine. I certainly can't. The place to start, and the only answer that anyone will ever give you, is check the person specification and the scoring matrix. Because if someone comes up to me and they know that I do neurosurgical research and they say, like, Ollie, I want to get into neurosurgery, what do I do? I will say, well, the first thing I will say is pick something else. The second thing I will say is you just have to Google the point scoring matrix for the most recent round of selection. That's all anyone can ever tell you, because it varies by specialty. There is no one size fits all, and it varies by year. Things change often in the weeks running up to when specialty selection opens. The rules change last minute. So the answer that I give, or that anyone else gives, can only ever be as good as the point scoring matrix. So just look there. One of the last things I want to talk about is the academic clinical pathway, which is something that I'd like you to all be aware of. And the point of this is that in order to make sure that we have enough people doing research in the future, clinical academics, we need doctors, physicians, and surgeons driving academic research in situ, in vivo, as it were. We need doctors that are trained as scholars and scientists. And the clinical academic pathway is basically the way that we ensure that we do this as a profession. And it combines your clinical training, so your years as a registrar, with academic study and work, usually in the form of a PhD. These are appointed in a slightly different way, but the most major difference is that they're run through, even in specialties that would not normally offer run-through training. So Mr. Nathan, for example, who is going to be around later in the series, I believe, for one of these talks, let's say that he finishes FY2 and he applies for an academic clinical fellow post, an ACF in urology. Despite the fact, remember, that you can't normally apply for urology until ST3, you would have to do core surgical training first. His ACF will be given to him immediately if he's successful. He enters as an ST1, and that means that he does not need to reapply for urology training at ST3. His ACF post means that he's guaranteed two things. He's guaranteed a PhD and research work and academic time during his clinical training and access to the academic pathway. And once he's got his training number, it's his until he finishes training and becomes a consultant. So for those of you that are academic and want to do a specialty that does not offer run-through training, but you want that security of doing run-through training, an ACF is perhaps the most simple way to do it. And then finally, the path's less traveled, and this is where I'm going to wrap up my talk, and we'll have a few minutes for questions. Very, very, very few people complete training the traditional way anymore. Foundation program, core training, higher training, consultant. And it's often not because people don't want to do that. It's becoming impossible to do this now because of how competitive everything is and the training bottlenecks. Everything is becoming more and more and more competitive. The government is unwilling to fund enough training posts, so everything is backing up and up. So people have to find other things to do. Now, F3 years are very, very common. People go abroad, people teach for a year, people do research, people do junior clinical fellows. That's obviously the type of thing that I'm doing. You can do an out-of-program experience at any time in your training, any time until you're a consultant, an agreed period of time out of your program to do something. So you might need 1 or 2 years out to do that. You might do a master's, you might teach for a year, you might do something else. People take time out to do PhDs and MDs, if that's what you want to do. You could go and work in industry, in pharma, consulting, go into medical politics, if that's what you like. There's MPs who are doctors on both sides of the political aisle, do locum work. Fellowships are very common. That's where you take time out of training or as part of your training to go and develop some very subspecialist experience in your specialty. Often people go abroad to centres of excellence for that. Increasingly common is less than full-time work. So 80% less than full-time, that is, you're doing 40 hours instead of 48, or the adjusted equivalent, 4 days a week instead of 5. That's now available to any trainee in any training program for any reason, in England at least. I don't know about in Scotland and Wales, Northern Ireland, but that's something to be aware of. And SAS careers as well. Rob Fleming, just Google his name. He's done all of the work that you need to know on this. But SAS is basically an opportunity to develop your own career as a specialist without rotating effectively. So developing your competencies and building seniority in the same unit with a supporting department in a specialty of your choosing. And there is a national contract that has been agreed for SAS doctors, for specialty doctors and specialist doctors, to protect their pain conditions that not enough people are using. So be aware of SAS careers. And that brings us to the end, 4 minutes before the hour. Are there any questions? I realise we've covered a lot tonight, and I'm very sorry that I have to say I'm not up to my usual animated self. I'm very weary, as I think you can tell. So thank you all for attending. You've been very attentive, and I'd be delighted to help you all if there's any way that I can do so. I'll put my email in the chat as well. If anyone wants to get in touch. And thank you, Burst, for having me as well. I'm very much not a urologist or know anything about bladders or testicles. True. Yeah, neuro does rhyme with euro. We can be confused on the phone at any time. To be honest, you guys that are at medical school, when you're an SHO and you're either the neuro or the euro SHO, there's no greater pleasure than picking up the phones for a referral, and then 2 seconds in they go, oh no, sorry, you're neuro, I wanted euro, sorry, and then they hang up, and then you can sit back and go back to sleep. Think, not my problem. Yeah, exactly. They'll have given you the full rundown. But if there's no questions, I'll close it at 8 o'clock. We'll see it the whole hour. All right, guys, I think we're about there. There's no questions forthcoming. Thank you all very much for watching. Thank you, Narika. Have a good night, everybody. And make sure that you come along to the next sessions. The links to register for the next sessions are out. All of those events are ready to sign up. So be sure that you do. And there will be more interesting than this one, I'm sure. So take care. Thank you, everybody.